Hello, I'm Jessica. I'm one of the senior registrar on call today. I believe that you are here today to ask my help and advice in your preparation for the presentation for the case, which you are going to present in the risk management meeting. Is that right?
Yes.
Okay, so don't worry, I'm going to help you and you will understand everything about how to do the risk management. Usually, when we do like these cases, we may discuss an incident report or a serious incident which has happened already. So the aim of that is to prevent that from happening again. So we need to know how to anticipate the risk, and we need to discuss what went well and what could have been better, and finally we will come with a learning plan. Is that okay with you?
Yeah.
Okay, so do you have the case notes for this scenario?
Yes.
Okay, so if you don't mind, if you can read for me the scenario, and I'm going to discuss it with you.
Okay. So, a 28-year-old patient, primary gravida, pregnant 37 weeks. Earlier in pregnancy, she was going as a low-risk pregnancy with normal scans and screening tests until 32 weeks, when she has been found to have a persistently raised blood pressure. She has been started on labetalol 200 milligrams BD for pregnancy-induced hypertension. Her blood pressure has been stable since that, no protein in urine, and baby moves well. Growth scan showed reduced growth velocity from the 80th centile to the 50th centile, and she's due to have another scan in 2 weeks' time. She has attended the day assessment unit today with the first episode of reduced fetal movement. Her urine dipstick showed +2 protein, and her blood pressure was 175/99 and 158/100, half an hour apart. CTG was normal, and she has felt few movements during tracing. They have sent the PET bloods and urine for protein creatinine ratio. She has been given a stat dose of labetalol 200 milligrams, and her blood pressure was settled in half an hour. The patient has been reassured and sent home. Changed her labetalol to be TDS with a follow-up appointment in 3 days' time with the community midwife to check her blood pressure.
Okay, so let's start from the beginning. So we have got a 28-year-old patient who is primary gravida, and she is now 37 weeks, and she has been diagnosed with a pregnancy-induced hypertension, and she is on labetalol 200, and it was controlled. Um, that's from what went well. Yeah, that is the correct treatment for the pregnancy-induced hypertension. Labetalol is one of the first-line treatment for high blood pressure in pregnancy. If the patient doesn't have any contraindication, like if she is asthmatic or any other like chest problems, so safely we can give her labetalol. And since her blood pressure was stable on twice daily regimen, then she should continue on that. However, if we look on her growth scans, which showed us a reduced growth velocity uh, from the 80th centile to the 50th centile, in spite not being a small for gestational age baby, but it is now intrauterine growth restriction. Um, with that, patient is considered a little bit risky, and it can give us a hint about thinking of uh, placental insufficiency. So we need to put an eye on this baby, and whenever anything happens, especially to the baby movements, we should take it serious. Um, the correct management has been done is to arrange another scan in 2 weeks' time. But what could have been done better here is to mention about what is the Lycor and Doppler, because we need to know um, if liquor amount is normal and whether the uterine artery Doppler is normal or not. Because if it is normal, then we will arrange another scan in 2 weeks' time as it is done. However, if anything abnormal in the liquor or Doppler, we may need to like put another plan, and maybe we may need to induce the patient. Regarding her presentation for the day assessment unit today, so she has the first episode of reduced fetal movement. We don't usually worry about the first episode of reduced fetal movement. We will be worried if she has a recurrent episode of reduced fetal movement. But taking in our consideration this high risk baby and patient, we need to take it serious, as I mentioned earlier, especially if her observations show a new event which is happening today. Her blood pressure is going up and her urine is showing protein. So what went well here is that we confirmed the high blood pressure in 2 occasions, and we given a stat dose of labetalol to control her blood pressure, and fortunately her blood pressure was settled in half an hour. The thing that CTG was normal is reassuring us about the baby at this moment, but it doesn't give us a future reassurance about the baby condition. Patient started to feel few movements during the trace, and that's also good because we need to ensure that the patient has felt movements before we disconnect the CTG. The problem that we have sent the PET bloods and urine for PCR, that's a good thing. However, we can't send the patient home until we got the results, because what is the point of doing investigations without discussing the plan of management with the patient depending on the results? So I think it was better to keep the patient until we got the results of these bloods, and especially the PCR or the protein creatinine ratio, because we are anticipating possibility of superimposed preeclampsia, and that should be confirmed. And if it is the case, we need to explain to the patient further and discuss with her the possible risks. The patient has been reassured and sent home. That's, from my point of view, is not a well-managed condition. However, we can keep the patient under observation and put her under frequent CTG monitoring, like TDS CTG monitoring, and also keep monitoring her blood pressure like every 2 to 4 hours for at least 24 hours, because now we are changing the dosage of the labetalol. She was on BD and now we given her TDS, so we are not sure if she will respond to the new dose or no. So it's better to keep her for 24 hours for blood pressure profile, and once we are sure that this dose is controlling her blood pressure well and her baby is doing fine over 24 hours and the movement of the baby didn't change or didn't reduce again, then we may be able to discharge the patient. Okay,
Okay.
so what happened next?
Okay, so the midwife called the registrar after 2 hours to review the blood results. The full blood count was normal, the liver function test was normal, the urea and electrolytes were normal, the coagulation profile was normal, the protein creatinine ratio was 98. The registrar plan hasn't changed after viewing the results.
Okay, So looking at these results, the thing that went well here, that we reached a diagnosis of preeclampsia. But what could be done better is to call the patient to come in for review, to discuss with her all the possibilities and the risks, because she has got a new condition called preeclampsia. She may develop eclampsia if it is not controlled. So my professional management is to admit this patient till her plan of delivery. And also we should discuss that with the on-call consultant or the senior obstetrician on call, and arrange a plan of delivery for this lady. Now we are 37, we can't leave it like that. We need a plan, we need to discuss with the senior, and we need to admit the patient for under observation. We can't leave the patient home at this stage. Okay, can you tell me what happened after that?
Okay, so the patient attended after 10 hours to the triage, as she hasn't felt her baby movement again for at least 6 hours. She has noticed some vaginal bleeding and abdominal pain. She thought she is starting into labor. Observations were as follows: BP 155/110, pulse 130, temperature 37.1, respiratory rate 18. The midwife was not able to detect the fetal heart by the handheld Doppler, and she noticed a fully soaked pad with fresh blood. She has pressed the emergency buzzer. The on-call registrar went straight away and confirmed intrauterine death by the scanning machine. Abdomen was really tender and rigid. Speculum examination showed mild to moderate active uterine fresh bleeding with closed cervix. They called for Cat-1 C-section. Consultant on-call has been notified. IV line, another set of bloods sent. Group and saved, started IV fluids. The patient then shifted to theatre, had a Cat-1 C-section with a stillborn baby of 2,350 grams. There was complete separation of placenta with lots of clots inside the uterus. They started 40 units Sint infusion, closed the uterus in 2 layers, and closed the abdominal wall as usual.
Okay, so this patient came by her own without calling or anything, with another episode of reduced fetal movement, and she hasn't feel the movement for 6 hours, and she didn't call. So that's another thing. We should notify the patient to report any other episodes of reduced fetal movement as soon as possible. Like if I'm going to discharge the patient, I have to give her some warning signs and symptoms. If you feel headache, if you feel blurring vision, if your baby movement is reduced again, or you felt anything which is not right to you, please call us as soon as possible. So this patient waited for 6 hours without feeling any movement, and the only thing that brought her to the hospital is that she noticed some pain and bleeding. So when she came, her blood pressure was on the higher side and her pulse rate was high. So I'm anticipating here abruption. Okay. And unfortunately, there was intrauterine fetal death. So the decision for Cat-1 C-section is the correct decision because the patient is having active uterine fresh bleeding. IV line inserted. If I'm there, I should insert 2 wide bore cannulas, so 2 lines to be inserted. Another set of blood sent. That's one of the things which went well, because we need to compare her bloods now from the morning bloods, because if her hemoglobin is dropped significantly, then we will estimate how much blood she lost at home or inside the uterus. Okay. And group and save, yeah, and we started IV fluids. That's very, very good management. The consultant on call has been notified. Yeah, that's a correct management. The patient then shifted to theater and she had a Cat 1 C-section with a stillborn baby of 2 kilo point 3. That's, I think, a low birth weight. There was a complete separation of placenta. So we have confirmed here placental abruption and lots of clots inside the uterus. So if we have antepartum hemorrhage and we confirmed placental abruption, we should think about the possibility of postpartum hemorrhage, and we need to take all of our considerations in preventing that from happening. But what happens here is they just started the 40 unit scent, they closed the uterus straight away and closed the abdomen. And I'm not sure what happened after that. So can you tell me after that what happened?
Okay, so the patient is now ready to be transferred from theatre. The midwife has found the inkapad full of blood clots. The registrar called to come. He examined the patient, and large amount of blood clots came out of the vagina. Then he saw active fresh bleeding. Total blood loss so far is 1,600 cc and still ongoing. They gave ergometrin 500 milligrams IM, carboprost 0.25 milligrams, and 1,000 micrograms of misoprostol. Massive transfusion protocol has been activated. The decision was made to insert Bakri balloon. Again, she has been put under GA for examination under anesthesia and Bakri balloon insertion. The patient has received 2 units of blood. The balloon has been kept for 24 hours under close observation. After that, it was gradually removed. Patient was stable post-operative. The registrar has handed over to the morning team and planned to debrief the patient on the next day. The patient blood pressure was a bit on the higher side for the next 48 hours, but was controlled by combining labetalol, QDS, and methyl dopa.
Okay, so let's start from the first sentence. The patient now is ready to be transferred from theater, and the midwife has found the inkapad full of blood clots. So our anticipation of the risk of PPH was correct. So the patient developed postpartum hemorrhage. Now the registrar came and examined. Now only they announced the total blood loss is 1,600 cc. So what could have been done better here? You know, they didn't notify us when we exceeded 500 cc. However, according to our guidelines, the midwife in charge should notify the surgeon when we exceed 500 cc, and when the blood loss became more than 500 and less than 1,000. And once we exceed 1,000, we should activate the massive obstetric hemorrhage protocol, not to reach this amount. So that's one of the things which should be done better. So they also give ergometrin and carboprost, and these two medications are strictly contraindicated in a hypertensive patient. I know sometimes during emergency you will go by your default, but we should take care with this medication. The patient has a high blood pressure and she went into theater with a high blood pressure. So before giving such a medication, we should think about the contraindications. So I don't think these are the correct medications to be given, even if the bleeding is continuous. Uh, we should continue the scent infusion and give the misoprostol. We can also combine tranexamic acid 1 gram and transfuse blood as soon as possible rather than giving a risky medication. The massive transfusion protocol has been activated, in spite being a late step, but it's like a correct management. And before that, we should notify the senior obstetrician or the consultant to come. Once we reach 1000 cc blood loss, we should notify the consultant to come, and that hasn't been done. So that's one of the things that could have been done better. And the decision was made to insert the Beckery balloon. That's one of the things that went well, because we need to go for the surgical management of obstetric hemorrhage sooner rather than later. If we keep the patient losing blood, and then if she goes into DIC, whatever we will do after that will be unuseful for her. So it's a good decision to start with the non-invasive surgical management, which is Beckery balloon insertion. So again, she has been put under GA for examination under anesthesia and Beckery balloon insertion. That will raise an alert in our mind. This is a return to theater. So the patient has been awakened from a GA, and then she put again under anesthesia. That's considered a return to theater, and it warrant putting a separate incident form for that. So we need to put an incident report for unexpected intrauterine fetal death, and another incident for return to theater, and a third incident for massive obstetric hemorrhage. Okay, the patient has received 2 units of blood. Okay, so that's a good thing. However, we need to know roughly how much her hemoglobin so far. We didn't have any information about the repeat bloods, and we should here send another set of blood after losing this huge amount in theater. Okay, so we need another set of blood to be sent, including the coagulation profile. So that hasn't been done. So that's one of the things that could have been done better. The balloon has been kept for 24 hours with close observation. After that, it was gradually removed. The patient was stable post-operatively. That's a very correct management. The registrar has handed over to the morning team and planned to debrief the patient on the next day. Sometimes you may need to stay a little bit and debrief the patient straight away rather than leaving her waiting to be debriefed later. This patient actually passed through lots of things, and she lost her baby, and she also experienced twice theater admission, and she lost blood, and she has lots of things happen. So we can't leave the patient without any explanation or any at least apology for what is happening. And also we need to do the duty of Condor and do everything. The best thing that he didn't forget to debrief the patient, but it is better to wait a little bit, and if the patient is understanding well and alert, we can debrief her. If the patient is not able to understand, we can debrief her partner, and also we need to debrief our team, the midwives and the theater staff. We need to do a team brief, because everyone will go into a stressful situation. Okay, the blood pressure was a bit on the higher side in the next 48 hours, and that's because we given some medication which are contraindicated in high blood pressure patients. but it was controlled by combining labetalol QDS. So we increased the labetalol to be 4 times daily. That's a correct decision. And methyl dopa. So methyl dopa is one of the contraindicated medication postnatally because it's a cause of postnatal depression. This patient is so easily have a risk to go into postnatal depression. She just lost a baby. We can't give her methyl dopa at all. Okay, so that's not a good decision. We can add nifedipine. We can add another like other antihypertensive medication, but we should avoid giving her methyl dopa. So what is the learning plan from this case? First of all, we need to be aware of the risk and anticipate it. So if we are having a risky patient, we shouldn't ignore her complaint. We shouldn't send the patient home and without knowing the results of the investigations we have collected. We shouldn't ignore her complaint about the first episode of reduced fetal movement if she is a high risk patient. We have to involve our seniors in each step. We need to estimate the blood loss uh, with each step we are in theater. So we should ask if the midwife forgot to notify me about the blood loss and I am anticipating a huge amount of blood loss. So while I am suturing, I can ask, can you update me about the blood loss so far? You know, just alert the team and communicate with your colleagues and know what is needed to be done. Please, massive obstetric hemorrhage should be announced once we reached 1,000, and we need to call the consultant to come at this stage, and we need to send another set of blood. And before giving any medication, please, that's one of the patient safety issues. Please ensure that the patient doesn't have any contraindication for this medicine. Don't use methyl dopa for a postnatal patient. It can be only used if the patient is having chronic hypertension, she felt pregnant, and we can use it early in pregnancy. It is not to be used neither in the third trimester or in the postnatal period. We should formulate a counselor to go and visit this lady. We need to prescribe for her some lactation stopping medication. We should go as a team and debrief the patient and apologize for her for what she passed through. We should do the duty of condor, and we as I told you, we need to raise 3 incidence forms. First of all, for the intrauterine death. The second is for the second or repeated theater admission or return to theater, and the third for the massive obstetric hemorrhage. So are you happy now to formulate whatever we discussed in a presentation and to present it in the meeting?
Yes, it's clear now.
Okay, that's great. So I hope you have got a benefit from this discussion, and hopefully, if you need any help at any time, you come and ask for my help. And if I'm free, I will attend the meeting and see your presentation.
Okay, thank you.
No problem. Thank you so much.